Aloha! That's the style. So it's nice to see so many people interested in emergency medicine. I love emergency medicine, and I see so many students. So this actually reminds me of when I was a student. This is so popular then. So we used to watch this show every day, well not every day, but once a week we'd watch this show. And I got so interested in emergency medicine. And I was going to ask you a question. Do you know which of these doctors is the pediatric emergency doctor? Anybody? I know there's not yeah.
The surgeon from right.
Yeah, so that's perfect. George Clooney. So if you look closely, it says pediatrics. Dr. Doug Ross, pediatric emergency medicine. So then I realized maybe I want to be like George Clooney. So I became pediatric emergency doctor. So the emergency department's, I think, the best department in the hospital because that's where the diagnosis is made. I think the best doctors work there. Even in Japan, I think the best doctors are there. So I'll be talking about some common pediatric conditions, x-rays of those conditions, and also recognize some hidden findings on those x-rays. So these are all x-rays that I've taken care of these patients. So this is a famous baseball player. And this is his kind of famous sentence. Experience is a hard teacher because she gives the test first and the lesson afterwards. So sometimes in the emergency department, we see something for the first time, we have to figure out what it is, and sometimes based on x-ray. So just a basic point, there's 5 densities on plain x-ray. These are air, like in the lungs, fat, like under the skin, soft tissue, like the liver, bone, like the rib, and then metal, because this child has swallowed something metallic. So the first case is a 15-year-old that came to the emergency department with abdominal pain, vomiting several times, and loss of appetite. She had a fever, but otherwise vital signs were normal. She was tended to palpation over the right lower quadrant. So we performed x-ray, abdominal x-ray. So you can see on the right side is the upright, and on the other side is the flat. So I immediately noticed there's decreased bowel gas here, not much gas, kind of some here in the right lower quadrant. Other important point is no pneumonia here, and then there's no free air under the diaphragm. And if you look at this side, you can actually diagnose appendicitis based on this x-ray. So often we use ultrasound or CT, but sometimes we can diagnose with x-ray. So I'll just show you, there's 2 things right here and right here. And then I think some people might know what those are. These are called appendicolith. So if you see this and then pain there when you press, this means appendicitis. So this patient went to operating room without any tests or ultrasounds or blood tests. Surgeon just took straight to OR. So another patient we had, 4-year-old with severe abdominal pain and vomiting. No fever, but she does have a rapid heart rate. And then her abdomen is very, very tender. So we got plain x-ray. And you can see this is upright x-ray. So the main thing for upright is you're checking for free air, right? So you can see that she clearly has a huge amount of free air. So this is all air, this is liver, and then her stomach is down here, as you can see the NG tube. So she went also directly to operating room, and she had gastric perforation. So the key point is, if you have this much air, it has to be very proximal, like stomach perforation. Like appendix perforation won't give you like this, of course. So there's another one with abdominal pain. This was actually a child visiting from Japan on a vacation, 18 months old, had severe abdominal pain, would come and go, and then would have vomiting for about 6 hours. No fever, no diarrhea, no bloody stool. And then there was some tenderness to palpation. So I was kind of concerned about something specific for this patient. So I started with the x-ray. So when I looked at the x-ray, I was like, wow, that doesn't look normal. So any ideas what that could be? Maybe you can think in your mind. So I was worried about a specific thing. I noticed also there's decreased bowel gas here. So there's also, I'm already thinking about obstruction. And then I started to look for a certain sign called donut sign or target sign. So if you look in the right upper quadrant, you can see a larger circle and then a smaller circle. And that's the donut sign or target sign. I'll show you the other again. But the key point is you can see the liver edge here, and then it disappears, it's gone, because something is right here. So if you look here, you see liver edge, yeah, see circle and circle. So that's intussusception, the target sign or donut sign. And that was pretty cool. So the radiologist still wanted ultrasound, unfortunately, so we did ultrasound, and then it shows clearly donut. So the next step, of course, is to do air enema or barium enema. We like air enema. So you can see the air is going up, up, and then here it's almost reduced. And see, now you can start seeing the liver edge, and there's a little bit of intussusception left. So this is most commonly ileocecal, so it's going to come up to the right upper quadrant. The most common ages are 6 months to 18 months, but it can be older also. And then what we look for is vomiting, severe abdominal pain that comes and goes. And then the last finding is the current jelly stools. And then sometimes you can feel a mass in the right upper quadrant. So this is actually what current jelly looks like. Because I know some people don't know. So it's very red, like mucus thing. It's actually tasty. So with current jelly, you should diagnose intussusception before the current jelly sign, because that means that your bowel mucosa is dying and it's coming out. So our goal is to diagnose before that. And to do that, to diagnose intussusception, you have to be intussuspicious, right? You have to be suspicious of the diagnosis based on the history. Here's another patient with intussusception, vomiting and abdominal pain. I thought, oh, is that a foreign body? But this is actually like a little metal charm that was on their clothes. And then, you can't see the liver edge, right? So that means there's a soft tissue mass here. This shows something that's called the crescent sign, right here. So this is another sign that we see with intussusception. And then here's another patient, and you can see again, you get soft tissue mass, and you cannot see the liver edge. So that's the main thing I look for plain film. Of course, ultrasound is the best test for intussusception, but many times the X-ray will be abnormal. So this is like this, who's seen the film Inception? This is like intussusception. It's like a bowel within a bowel. So this is another patient, 50-month-old, who had an episode of choking at home. And then his parents thought, well, maybe he swallowed something, but they weren't sure. And so we got an X-ray, basically foreign body X-rays, like the whole body. And you can see there's something there. It looks round. So and it looks like it's probably in the stomach. So it's one of two things. Does it look like a coin or a battery? And you can see there's kind of a little ring, so it's probably a battery. So usually if it's in the stomach, a battery is felt to be okay. This is 12 hours later, but it's still there. And so the question is, do you need to call a surgeon? I think I spoke with a surgeon. They said, let it wait 12 more hours. And there you can see clearly it was a battery. And then after 12 hours, it actually passed in the stool. There's no problem. So generally, if it's in the stomach, it's okay because it's going to move quickly. If it's in the esophagus or the nose, then it's an emergency, and I'll show you. So this is another patient we had. Kids love to stuff things up their nose. So coins or Legos or anything. So you can see there is a nasal-foreign body. And then on that view, you can tell it's disc battery. So this one is emergency. You have to get this removed as fast as possible. The reason is it's going to cause severe burns. So this is a publication. They took a hot dog and put battery there. And then after 3 hours, that's how it looked. And then they cut open. So even after a few hours, severe damage can occur to nasal mucosa or esophagus. The other ones, oh sorry, here's another case. This is a 20-month-old who choked on a snack bar about 3 weeks prior to coming to emergency department. But mom was concerned because he kept coughing and was getting worse. And when he was in the emergency department, oxygen level was about 96% on room air. And you can't really examine him, he just starts crying. So we got an x-ray. And you can see it definitely looks different from side to side. So the right side looks a little bit increased density. The left side almost looks like too inflated, right? So the best way to tell which side is abnormal is to do decubitus x-rays. So I had the patient go back to radiology. So this is right side down. You can see that the lung gets smaller, deflates. And then with left side down, it doesn't really deflate that much. So we can suspect that the foreign body is on the left side. So we ordered bronchoscopy. And this is what the pictures look like. So this is actually his left mainstem bronchus, and there's all the scar tissue. It was almost completely closed off. And so we had to get surgery for that. The other one that this is one that we used to see a lot of. This is 2009, a very popular toy was released. It's like these little tiny magnets that are really super strong. In the US, they're called buckyballs. So they actually got the Toy of the Year award because they were so popular. The problem was kids started eating them, like kids do. And so we started seeing patients in the emergency department, kids who eat the buckyball magnet. So this is what they look like. And actually, they still have this in Japan, I think, right? I bought some last year. So you can see how they're super strong. They can hold up this heavy wrench. So the problem is kids start swallowing them. And when you swallow them, they want to attach to each other, so it causes bowel perforation. So anytime you see this, we had to call the surgeon, had to remove them. Here you can see two small buckyballs there, but you can see like they're not quite touching. That's because they have bowel between them, and then it's going to cause bowel perforation. So this patient was actually in the hospital for several weeks afterwards with a severe bowel perforation. So because of that, we actually had several deaths in the United States and thousands of emergency department visits. So 3 years later, after being Toy of the Year, after 3 years, they got banned from the US. So you can't buy them now, it's illegal. And so hopefully we don't see those ever again. So here's another patient who swallowed something. So you can see up here. It's like a screw. So kids will swallow everything. And then here's a patient I saw. This is kind of like a saying in English. It feels like your heart is up in your throat, like you're really nervous. This is what it looks like on X-ray. It's like a heart attack. So we see kids will swallow anything. So this was an interesting one. This is a 3-day-old male, and the chief complaint was poor feeding. The mom is a teenager, so the nurse said, I think it's just a young mother. She just needs to work with feeding more. And no problems with delivery. But interestingly, there was no stool in the first 24 hours of life, which is a little bit rare. And so you're concerned about a few things there. So like, no vomiting, no, which is good. And when I examined the baby, the abdomen was distended, and then it had a small spit up, which looked bilious. So I became concerned. So I got abdominal x-ray, and you can see already it looks abnormal. There's multiple air fluid levels here, and it looks like a lot of gaseous distension. And then you also notice that there's no air in the rectum, which is interesting. You should be able to see air there. And so on the other view, again, you can see lots of gas. And then if you look closely, I was looking at the bowel wall, and like, what is that? There's something there. So if you look a little bit closer, you can see this is probably small bowel, and this is large bowel. But see those like little air bubbles? And they're in multiple ones. So this is something that you usually see in premature babies. But this is a baby that was full term and was healthy. Well, we thought was healthy. So this is small air bubbles right there. This is called pneumatosis intestinalis. So this is what basically diagnosis is necrotizing enterocolitis or NEC. So the key point here is full-term babies don't get NEC unless they have some severe problem. So the baby was admitted to the hospital, and they did a rectal contrast study. So you can see it's clearly abnormal. Here's the tube, which goes in the rectum and gets the contrast. And then the proximal large bowel is very dilated, and it becomes very tiny. It can't relax, right? It's like really, really tight. So you guys probably know what this one is. This baby ended up having Hirschsprung's disease. So the Hirschsprung's disease was the main problem, and because of that, they developed necrotizing enterocolitis. So this is a little bit on Hirschsprung's disease. It was actually discovered 1888 by a pediatrician in Denmark, Harold Hirschsprung. It's actually the most common cause of neonatal colonic obstruction, about 20%, up to 20% of obstruction. And the key point is there's usually delayed meconian passage after birth. So I usually ask the parents, like, when did they, first time they pooped? And it was like day 2 of life or day 3 of life. It's hardly ever the first 24 hours. So that's something we always ask after a baby's born. And that's how many live births, about 1 in 5,000 live births it happens. So here's another patient. This one was a 3-year-old female vomiting. This for like about 24 hours. Initially it looked just like milk, but then it changed and become bile color. No fever, diarrhea, and then the abdomen's kind of big and a little bit tender and kind of everywhere. So we got an x-ray. And you can see clearly it does not look normal, right? There's hardly any gas here. And there's a huge stomach bubble. And so because of the bilious emesis, our next step is to order upper GI study. So we got upper GI, and you can see out there's so you can see the stomach, and it comes out of the stomach through the duodenum and it makes this little corkscrew sign. So this is, when you see this with upper GI, you can basically diagnose volvulus. So this is what midgut volvulus looks like on the upper GI. And so at this point we call surgery to fix it. So this is why it looks like corkscrew, is because when it twists, it's going to make like that. So this is what we call corkscrew sign. For many of the medical students in the US, it's a little bit confusing between malrotation and volvulus. So this is what how I kind of learned the difference. Normal, the small intestine is attached with a long attachment like that. Malrotation, the attachment's very small, and so it's going to be easy to get twisted. So malrotation puts you at risk for volvulus, but they're two different things. Oops. And you can tell basically when you do upper GI, the position of the duodenum, like that, is going to be different. So malrotation again puts you at risk for volvulus, but they're different things. And then basically if you have a small baby and they have bilious or bile in their vomit, you consider it volvulus until proven otherwise. And you have to do upper GI series. So this is another foreign body case. Like I said, kids love to swallow things. So this is an older child. So she had a pop can of like soda pop or Coca-Cola, and there's that little aluminum tab. So for some reason she broke that off and decided to swallow it. So kids in the US do things like that. So she swallowed it, and it doesn't sound concerning. We didn't want to do anything, right? She looks fine, no pain. We're like, well, just go home and just watch for it. But then the mom was like, oh, why don't we do x-ray? I'm like, okay, we'll get x-ray. And so we got an x-ray, and I couldn't see any foreign body there. And then the only one I see is she has an earring there. And then the rest of the x-ray is here. And if you look in the area of the stomach, you can actually see a foreign body, which is the aluminum up right there. So that's where the can tab is. And so we told the mother, no problem, this should just pass. Just watch for it in the stool. And then the radiologist calls us the next morning because they double check the x-ray, right? And so he asks, you know, was the girl having any hip pain, like pain in her hip? And so we called the mom, and like, was she having hip pain? And the mom said, yes, she's been having hip pain for 2 or 3 weeks. And The reason is, if you look closely at her hip exam, she actually has right-sided slipped capital femoral epiphysis. So this is the physis, right? The physis. This is the epiphysis, which is like the ice cream on the cone. And this is the diaphysis and metaphysis. With Skiffy, this is the ice cream basically slips off the cone. So if you draw these lines that are called Klein's lines, so you can draw it on both sides. This should intersect the epiphysis like this, but on the right side it actually completely misses. So she has the right-sided Skiffy. So she had to come back and get surgery actually. Is this common in Japan? Dr. Kim, do you know?
No.
Not so common?
Oh,
Oh, okay. Has anyone ever seen this? It might not be common because the risk factor, well, I'll talk about it. Okay, so she had to get surgery. So another patient I saw, this is a 9-year-old, she's kind of obese, which is risk factor, so maybe that's why it's not common in Japan. So her chief complaint was limping, and then she had knee pain. And she had it, I don't know, for a couple of weeks. And then we examined her, she wants to keep her hip like externally rotated and flexed. That's like her most comfortable position. And then so we got x-ray, and you can see she also, if you draw Klein's lines, you can see that this side it intersects a little bit, and this side it misses. So she has on the left side is skippy. So we told her mother, you know, she can go home, but she needs to rest in bed, no activity. And she'd come back for surgery in a couple of days. So unfortunately, she decided to walk around, and she actually fell, and then it became like this. So you can see it's like the ice cream slipped off the cone. So because of that, it got acutely worse. She had to go emergently to surgery and get the screws there. So that's how they fixed it. And then luckily, this is after about 3 years, the screws are removed once the physis is closed and the bone is strong. And then this is a person that has a bad skiffy on this side, and then this is mild. So 20% of the time, it's actually on both hips. So many times if they do surgery on one hip, they do surgery on both hips actually. So we see it, it's actually more common in boys than girls, but the key risk factor is being obese. And it's more common in African Americans in the US. And I think the key point is the pain is, like the problem is in the hip, but then the pain is experienced in the knee. So a lot of times the chief complaint is knee pain. So anytime we see a child with knee pain or limp, we always do x-rays of the hips because it's so common. So here's another orthopedic case. This is a 2-month-old male with the chief complaint of fussiness and crying. Just kept crying. It was only for a couple of hours though, and then no fall, no trauma, nothing really had happened. He seemed like pretty normal, looked okay, very busy, so we think let's just recheck him after half an hour, see how he's doing. And so we rechecked him, and he was able to drink his bottle, no vomiting, but he's still fussy, so I kind of re-examined him again, and I find out that his left thigh is real sore to touch. So we got an x-ray, we're like, oh no, look, kosetsu. And so, of course, if it's 2-month-old with a broken femur, we're worried about child abuse, right? So I told the parents that I'm worried about child abuse, I have to call the police. So we got x-rays, which is skeletal survey, x-ray of all the bones of the body. It was actually normal, except for the femur. And, you know, the history doesn't make sense. So I called our orthopedic doctor, I called his doctor, and I decided to go back and talk to the family more. So I take family history, and actually many people in the family had history of easily broken bones. And so I still reported to the police, and then there was more testing, and then actually what happened was osteogenesis imperfecta. And you can see this is another patient, but you can see how there's multiple broken bones everywhere. So this means you have to take a careful history on these types of cases. So this is another one, 3-month-old, who also had onset of thigh swelling. And this is the skeletal survey for him. So you can see this is his arm, and this is his leg. The bad part here is you see actually a fracture of the radius and also a tibia fracture. So this is a 3-month-old with already multiple fractures. So this one is clearly child abuse. So this is why we need to be careful in pediatric emergency medicine. Now sometimes these fractures actually can be something more normal. So this is an 18-month-old that was basically refusing to walk on the left leg. So he was taking a nap, he woke up, and then his foot kind of got caught. No fever, and then he is a little bit sore over the tibia. So we got an x-ray, and you can actually see that there's a slight fracture right there. You can see it better in this view. So this one, this is actually a common one in pediatrics. This is called a toddler's fracture, or like a fracture of around 2 years age. And this one can happen after minor trauma. So if the parents come in immediately and the story makes sense, we don't actually concern about child abuse. This is like, for some reason, it's a common fracture in this age group. We call it toddler's fracture. So this is another, volleyball is very popular in Hawaii. So this was a 16-year-old male who was playing volleyball and the finger got jammed. And this is what his x-ray looked like. So you can see he's got dislocation at the PIP joint and the DIP joint. And so this is the first time I've seen multiple dislocation like that. And so I did a digital block and fixed it. And the key point here is you want to relocate the distal part first and then the proximal part. This is another patient we saw. This was a 3-year-old who was playing on the playground equipment, which we call like monkey bars, and fell and landed on his arm, kind of straight arm. And definitely has some swelling, tenderness to the elbow. So we were worried about fracture. So we got an x-ray. And here's what this x-ray looks like. So the pediatric elbow x-ray is kind of complicated to read because the joint has to be able to extend, flex, supinate and pronate. So there's a lot of different motions. And there's many different areas of growth plates. So that what we do to help us is I didn't see an obvious fracture. There's a couple lines that we draw. One is the anterior humerus line. So that line should intersect this right here, which is called the capitellum. And if you draw a line down the radius, the same way it should intersect the capitellum in both views. So we know there's no fracture and there's normal alignment. So the question is there anything wrong with this x-ray? So if we look a little bit bigger, you guys can probably see there is something wrong. This is what we call a posterior fat pad sign. So if we see this, this is basically fat that usually is not visible, but there's effusion in the joint, so the fat is pushed back to where it's visible on the x-ray. And if we see this, we assume that there's an occult fracture there, a hidden fracture. So we're going to put him in a splint because it's considered probably a fracture. He also has a little bit of anterior facial fat pad sign too. And so we'll put him in a splint and have him follow with orthopedics. So here's another patient who fell and hurt their arm. And you can see he clearly has an ulna fracture. And then because the ulna and the radius, are right next to each other, usually if one is broken, something's going to happen to the other one. So we always have to be careful about that. So we see an ulna fracture, and if you're not careful, you say, oh, just put splint and discharge. The problem is there's something else wrong. And that is, so if you draw the line down the radius, it does not intersect with the capitellum. So this is a fractured dislocation. And then this one, there's a special name for it. I know some of you know this name. This was actually discovered by an Italian in the 1800s. So this is called a Montesius fracture. 1814, that's a long time ago. So we were able to, we did sedation and we reduced it, and now you can see that the ulnar fracture looks better, and then the radial head is now lined up with the capitellum. So now he can get a cast. So this is an older patient, 15-year-old, who was skateboarding and fell onto his arm. Again, you can see he clearly has a distal, now this time it's a distal radius fracture. So again, we're going to worry about something with the ulna, right? Because something probably happened with it. So if it looks okay in this view, if we get the other view, we can see our fractures there, but you can see that clearly the radius, the ulnar joint is definitely dislocated. So this is also one with a famous Italian name. This is a Galeazzi fracture. So this is one we have to, so we have to fix this and then put him in a splint. So now I'm going to go over a few x-rays, soft tissue neck x-ray. We do this kind of x-ray for many different chief complaints. So this is basically what a normal soft tissue neck x-ray should look like. There's some key points. So of course the vertebra look normal. The space right in front of the vertebra is called the prevertebral space, or it's also called, because the pharynx is here, it's called the retropharyngeal space. So this should be really a thin, tissue. It should be less than half of a vertebral body. So you can see this is nice and thin. And you always want to look at your epiglottis. The epiglottis should look like a thumb on its side like this, but it shouldn't look like that. That's called thumbprint sign, which is epiglottitis. And then you also look down here for swelling. This is where croup swelling is. So we had, first was a 2.5-year-old with history of trisomy 21. He came to the emergency department with some cough, runny nose, a little bit of fever, but the cough had kind of a different sound. It's like barky cough, like ho, ho. And then when he breathed in, there's a stridor, like that. So we gave him racemic epinephrine treatment. We gave him steroids because we were worried about croup, right, clinically. And he was kind of in respiratory distress, so we actually got an x-ray. And so if you look at his x-ray, if you think back to what we were looking for, prevertebral space is narrow, there's no swelling. You can see there's a lot of air here, so it's kind of like air trapping. His epiglottis looks okay, it looks like a thumb. And then down here, there's subglottic edema, which is what you see with croup. If you get the view on a PA x-ray for croup, you'll actually see up here, this is what they call a steeple sign. So that's the subglottic edema. And then this patient had a history of congenital heart disease. So you can see that this is probably right atrial enlargement. So another patient with throat problem. This was a 14-year-old that was visiting from Canada. We get many visitors, of course, in Hawaii. He had high fever, very sore throat, difficulty swallowing, and then the problem was no immunizations. So we're worried about epiglottitis, right? There's no Haemophilus B immunization. So he was seen at another clinic and transferred to our hospital to evaluate. So we got soft tissue neck x-ray. So the good thing was right away is his epiglottis looks normal. See right there. And then the next point, look, is the prevertebral space. How does that look? It's kind of thick, right? So there's definitely swelling there. So there's some kind of swelling, and he has fever, sore throat. So the next step for this patient is to get a CT of the neck with IV contrast. So this is his CT. So you can see again the epiglottis looks normal. It's nice and thin. But the area, this is the vertebra, so the prevertebral area is right here. You can see it's swollen, it looks a little bit dark, and then there's a little bit of enhancement here. So this is kind of what you see with an abscess or an infection like cellulitis. And so he had to be admitted to the hospital for IV antibiotics. So this is basically what retropharyngeal abscess looks like on CT. So this is a 3-year-old male. This one also had high fever, stridor, but this guy actually looked pretty sick. So again, no immunizations. And here's what his actually looked like. So you guys can see prevertebral space looks okay. But then if you look at his epiglottis, it looks horrible, right? So this is what the thumbprint sign is. So this is epiglottitis, so this is a true emergency. So you have to basically secure his airway, usually anesthesiology or ENT specialists would do intubation and then antibiotics. And this X-ray is from like 15 years ago because it's so rare now after immunization. I don't know, do you guys ever see it in Japan? Yeah, I personally have never seen it either, and I've been working for more than 10 years. And I never saw it in residency or fellowship either. But this used to be a big problem before the immunizations. But that's what it looks like on X-ray. So this was okay, jog my memory. This is a 15-year-old male, kind of a big, hefty guy. He'd actually come to the emergency department several times for difficulty breathing, kind of wheezing. They give him some breathing treatments. He felt a little bit better. So then he would go home. He also had some coughing, and he would actually cough up blood a couple times. So he came to our emergency department again, and I started albuterol breathing treatment, and I thought I'll check him later. So the nurse calls me. He's like, "Hey, Dr. Eakin, I think you might want to check him. He doesn't look too good." So I go in the room, and he's like sticking his neck out like this, like tripoding, and he's like having inspiratory and expiratory stridor and difficulty breathing. And so, because it's upper airway, I gave racemic epinephrine treatment, and I gave him intramuscular decadron or dexamethasone, and he got a little bit better so we could get an X-ray. So I got a soft tissue neck X-ray. And so you guys look at that. You definitely see there's air trapping here, which makes me worry about airway obstruction. Epiglottis looks like a thumb, right, on its side, so that's normal, no thumbprint. Prevertebral space is narrow, so no retropharyngeal abscess. But then I looked at his trachea, his airway, like what in the world? So he's got this thing right here. So I describe this like a flesh density tissue mass. So all of the air that he's breathing is going through this little tiny space. So we called the surgeons and the ear, nose, throat specialists and took him to the operating room. And they found the soft tissue mass, and this is what it looked like. This was in his trachea, and you can see it's very vascular, so that's why he was coughing up blood several times. And so when they did the pathology, it was a schwannoma. I think is that correct? Yeah. And so, schwannoma, so I'm so lucky that the ENT came, because otherwise I was going to have to do a cricothyrotomy. And he was like this big fat kid, it would have been very difficult. So 6 months later, he comes back to the emergency department and tells me that he feels exactly the same as before. I'm like, oh no. But luckily he looks fine this time. And so I get an X-ray again. And so here's the X-ray, original X-ray, and here's 6 months later. And luckily nothing is there and everything looks normal. Because I was worried that it had grown back, another schwannoma, but it was okay. Okay, so this is a healthy teenage boy who was in high school. If you guys have any questions too, I know I'm trying to finish on my time. He's a healthy boy who had presented with chest pain and difficulty breathing, just a little bit difficulty. He'd actually been at band practice for about 3 hours, and he carries like this heavy drum set, and they're marching around, and he has his chest pain. No fever or cough. He's kind of this tall, slender boy. So I got a chest X-ray and normal vital signs. So here's what his X-ray looked like. So I was worried about pneumothorax because he's like been, carrying something. This could happen spontaneously in teenage boys. And so I looked at the X-ray and I was like, oh, what does he have? So if you look carefully on one side, he does have a pneumothorax right here. So the top of the lung is right here. And you can see it goes all the way down. And then there's one other finding that can help you see which side. When he had pneumothorax, when it opened, there's going to be a little bit of fluid or blood. So if you look carefully, you can see it right here, there's a small pleural effusion. This side is nice and sharp, but it's only on the right side. So he has a moderate pneumothorax, so we had to put in a chest tube. Now you can see the chest tube coming up, going here, and the lung is expanded. Has a little bit of atelectasis here, and still a little bit of fluid there. So here's another patient we saw. He was actually a teenage boy as well. And he came with, actually, he said his whole chest was free, both sides. And then he was having some difficulty breathing. So, but he was able to walk into the emergency department. Walked in and breathing a little bit fast, but oxygen level was okay, no problem. So I said, let's get an x-ray, no fever or cough. Here's what his x-ray looks like. I was like, oh snap. So he has actually severe bilateral pneumothorax. So this is his lung right here, on both sides. So what I learned from this one is we actually have a lot more lung tissue than we need. Because he actually had pretty normal vital signs, even with his lungs like completely collapsed. So this is another patient. This was a 10-month-old with presenting with fever and cough for 2 or 3 days. And he looked totally fine. I told the mom he probably has a virus, but she was kept asking me, like, I'm really worried about him. Maybe we can do an x-ray. Let's just do an x-ray. I'm like, okay. So we did an x-ray. And then I told her, I looked at the x-ray quickly. I was like, I think his x-ray looks fine. There's no pneumonia or anything like that. And then the mom said, oh yeah, by the way, he fell on his chest earlier this week. I go, oh really? That's interesting. And then I realized I should check the x-ray a little more closely. And if you do, you can see he's got rib fractures on 3 different ribs. So I think the mom was a little bit, she knew something had happened to him, and that's why she wanted me to get the x-ray. So even if you're looking for pneumonia or some process, you have to look also for other diagnoses. So he had rib fractures, and so we had to diagnose his child abuse. And here's another patient we saw with kind of a similar story. And you can see there's a rib fracture there. So that's already healing, and there's one there. And so these are posterior rib fractures, so it's fractures in the back. This one only happens basically if you grab the baby and shake them like this. So this is like definitely child abuse, no question. So this is a patient, we have this kind of patient sometimes. So here's a 17-year-old who had a crazy party the night before and drank a lot of alcohol. And he woke up in the morning and he couldn't remember what had happened. But he came to the emergency department because he said he had some chest pain. I'm like, okay, what happened last night? He's like, I don't know, I can't remember anything. That's not good. So I got an x-ray. I don't see any pneumonia or anything. You guys probably see there's something wrong. He had like multiple fractures. So this is a good point not to drink too much alcohol. Okay, I think this is my last case. This is 10-month-old who came to the emergency department with sudden onset of difficulty breathing. So he was just playing around at home, and his parents said, yeah, he just started breathing heavy. And so he came to the emergency department. He's like difficulty breathing, respiratory distress, oxygen level is low. Oxygen level is low, 88% on room air. So we start oxygen. That's a little bit better, so I can listen to him. There's no breath sound on the left side. And then we're able to do an x-ray. So I was concerned about foreign body aspiration because he was playing around at home. Maybe he swallowed a coin. Or the other possibility was like pneumothorax, and then something like that. So I got an x-ray, and that's what the x-ray looked like. And I'd never actually seen this condition before. I only heard about it. And so I had to figure out what was going on. So you can see clearly there's a large collection of air here, right? And some sort of a structure here. The worst part of this, though, is because it looks like it's expanding, his trachea is shifting over, and the mediastinum is shifting over, so it's a tension situation. So you have to figure out what this is, within several minutes, otherwise he's going to die. So anybody know what this is? Who hasn't seen this X-ray before? Any ideas? I know some people saw this earlier this week. Yeah. So he has a diaphragmatic hernia, right? Now it's interesting is he had X-rays before this and they were normal, and ultrasound in birth was normal. So you're totally right. He has a diaphragmatic hernia. So the question is, what is this structure? Yeah, so that's his stomach. So I've never seen one present like this, but the problem is he keeps crying and crying, and then the stomach is getting bigger and bigger and making everything worse. So then I had to decide what my next step was, and so, what do you think? Yeah, perfect. So many people, when I ask them, what should we do, they're like, oh, do surgery. But we have to save his life first. So I told the nurses, like, get an NG tube in as fast as possible. And that's what we did. So you can see now the NG tube is down. It goes down, but actually goes above the diaphragm. But this is the stomach, but now it's decompressed. The other option you could do is do needle decompression, because that will save his life also, but then it causes a valve perforation. But at least you saved his life. So we did that. Then at this point, he's stable, so you can call the surgeon. And he went to the operating room that evening. You can see that the lung hasn't expanded, but the surgeon said, yeah, he had a small diaphragmatic hernia, which had never caused a problem before. This is how he often presents, is like this. This is a patient who came in with vomiting, but otherwise looked fine. And so we got an X-ray, you can see all of this. This is actually small bowel. So if you listen here, you won't hear breath sounds, you hear bowel sounds. And so she had to get surgery also. So this is called late presentation of diaphragmatic hernia. Usually it happens before birth, and they'll have malformation of the lung and they'll get pulmonary hypertension. This one, they were born normal, but their hernia was there, and then the abdominal contents come through later. Because she also had X-ray before this, it was normal. So it's a late presentation. So I think that's my presentation. So I think X-rays are really a great tool in the emergency department. They help us a lot. I order X-rays every single day. And I guess my key point also is emergency medicine is a great career choice. So I encourage you all to pursue that as much as possible. And I'm happy to take any questions.
Thank you, Doctor. Any question?
Oh, thank you very much for your great lecture showing us impressive X-rays. And I have one question.
Mm-hmm.
You showed us one patient with appendicitis diagnosed by only abdominal X-ray.
Mm-hmm.
It is amazing for me and maybe all participants because in Japan we usually use ultrasound of abdomen, and we often perform CT scan because we can easily perform it. Is it usual case for in your institution or the United States to diagnose appendicitis by only X-ray?
So that case, I believe what happened was the resident actually ordered the X-ray. Because usually we do ultrasound first. Yeah, so I think the resident ordered it by mistake. And then, which is okay, it's an X-ray. So then we saw like, oh no, it's appendicitis. So our usual course is to order ultrasound first, and then using the ultrasound, and then, we use the pediatric appendicitis scale basically. And so based on the ultrasound results, the history, the physical, and the white blood cell count and the CRP, we basically put a pediatric appendicitis score. And at that point, it's either go to the OR, be admitted to the hospital, or go home with close follow-up. We hardly ever do CT anymore for children. Adults, it's just do it. But yeah, the pediatric surgeons want us to decrease the amount of CTs, so it's all ultrasound. But that case was found just by chance. But they say that appendiculitis are there in about 10% of patients actually. That's kind of that's what they estimate. But that's actually the only case I've ever seen. Yeah, so good question.
難しいですね。レントゲンだけでは発表診断する。ただ、この全般の中でレントゲンの講義のように、子供ってやっぱり CT 取りづらいので、まだまだ小児の領域ではレントゲンが活かせると思うので、そういったメッセージも先生から。Thank you for that.
Oh yeah, you're welcome.
そしたら先生に最後に大きな拍手をお願いします。